So first, we invite Professor Rimassa.
Yeah, thank you. So regarding what Professor Chan was very nicely presented in his talk, I would like to add that, of course, we don't have so many options for patients with a biliary tract cancer, but we have more and more, moving from immunotherapy in first line, targeted agents, not only for FGFR, but also for other targets in second line. And importantly, we are now thinking of the possibility of combining surgery or locoregional with a systemic to try to improve the prognosis of our patients. And regarding the questions, so for patients with advanced stage biliary tract cancer, now we use chemoimmunotherapy in first line, and we are starting seeing long-term results also for patients with biliary tract cancer, as we are seeing already for patients with HCC. For instance, now we have for the TOPAZ one, so the combination of cisplatin, gemcitabine, and durvalumab, we have data in terms of overall survival at 3 years, or even very, very recently presented at the EASL Liver Cancer Summit at 4 years. So we have more than 10% of patients alive in the long term with advanced biliary tract cancer. And this is something that is, again, unprecedented because we didn't have these results in the future. The problem is that in the end, eventually all the patients progress or have other reasons to stop the treatment. So we are not yet seeing so many patients living in the long term as we are seeing for HCC. So probably we need to better understand the disease and to try to understand why some patients do very well with a chemoimmunotherapy, while some patients progress very early. Okay, we have data for chemoimmunotherapy. We had trials trying to combine also anti-angiogenics like bevacizumab, but with no clear benefit. So probably the standard of care now is still remaining in first line chemoimmunotherapy. The other important point is for the future to consider if for patients with actionable alterations, we may add, and there are ongoing phase 3 trials in first line, if we may add also targeted agents in first line. So if we can think of, let's say, quadruple combinations like chemotherapy, immunotherapy, and targeted agents, we will see the results in the near future. I think this for first line treatment for patients with advanced disease, these are the main points now.
Thank you for your opinion. So it's very difficult to choose the first line treatment for the targeting therapy because we look forward to some clinical trial results. It's not they are not very clear now, so we appreciate. So let's welcome Professor Xiaofen Li. Xiaofen.
Thank you, Professor Tao. Thank you for Professor Chen for your wonderful lecture. I think there's no doubt that combination of immunotherapy and chemotherapy has benefited patients with BTC. But however, we also note that the absolute increase in overall survival is less than 2 months. So I think maybe the future research we may focus on identifying the optimal population for immunotherapy and predictive biomarkers for its efficacy. Moreover, tailoring chemotherapy regimens, targeted drugs, and local treatments based on the specific location of the primary tumor, its blood supply characteristics, and tumor burden may enhance therapeutic outcomes. As for local regional interventions, including SIRT, HAIC, TACE, and radiotherapy, I think they do have some benefits to our local advanced tumors. But I think that for patients with good physical conditions and who wish to control liver lesions as soon as possible, or strive for a surgical resection, I think the combination is beneficial. For lesions with better blood supply, SIRT or HAIC can be given priority consideration. And I would like to ask Professor Chen some questions. I noticed that gallbladder cancer patients respond poor to our standard GC plus immunotherapy. Sometimes maybe other like GAP chemotherapy maybe response better. I want to ask you how to choose chemotherapy regimen in your practice.
I understand your point because we know that the BTC is a heterogeneous disease, and often in subgroup analysis, whatever trials, whatever regimen, you do see some different kind of effect or efficacy in the gallbladder subgroup, the ICC, or the extrahepatic.
Yeah.
And of course, we are quite inclined to choose a regimen based on this subgroup analysis. But I can tell you in my practice, maybe we can talk to ask Lorenza as well. I try to avoid by choosing my regimen based on this subgroup analysis. I tend to just give doublet together with the PD-1, either durvalumab or pembrolizumab, without considering subtypes. And then, of course, after the response, then I can adjust my second-line regimen based on the previous response. I know that sometimes based on the phase 3 study, we may consider GEM-CIS plus nab-paclitaxel. Hopefully, we could induce some better outcome in those gallbladder. But of course, this is at a cost of toxicity. And we know that overall survival, they are not that significantly different from the GEM-CIS. So I tend to not adjust my regimen based on the subtypes. But on the second line, I tend to tailor-make a bit. I know FOLFOX have been considered as a standard second line, but I tend to adjust it based on the previous response. So maybe I can go back to Lorenza. Will you say for gallbladder, will you use a different chemo backbone, or you still use just a 2+1 or the 966 regimen?
Thank you, Stephen. This is a very, very important point. I agree with you. We use the combination of cisplatin gemcitabine and in one immune checkpoint inhibitor, so either durvalumab or pembrolizumab, without taking into account the subgroup analysis, even if, as you mentioned, for instance, with the cisgem nab-paclitaxel, there is a clear in the exploratory analysis benefit for patients with gallbladder cancer. So again, exploratory analyses are not powered to show a real benefit or a real difference. So in first line, I use cisplatin gemcitabine immunotherapy. And then for first line, of course, for second line, of course, I consider the molecular profiling. And we know that, for instance, for patients with gallbladder cancer, more frequently we have alterations in HER2, like HER2 overexpression. We may offer HER2 targeting agent if available, and we may consider to adjust the second line based on the molecular profiling and based on the response to first line. But in first line, I will not preclude a patient to receive the combination that is overall most effective, even if it's just 1 year overall survival as a median. So cisplatin gemcitabine immunotherapy.
Thank you. Thank you all.
Can I ask a question? In China, say for gallbladder, if you want aggressive treatment, or what will be your standard first line in China when you encounter usually gallbladder quite advanced metastatic, right? So what will be your options in China? Can I learn from you your experience?
I answer Professor Chen. In our clinic, if the patients have good physical condition or the tumor burden is very heavy, we usually use GAP chemotherapy. Usually we use GEM-CIS plus immunotherapy.
So still gemcitabine, cisplatin, and immunotherapy, right?
Yes, yes.
Okay. So we use triplet? We use a triplet chemo or even triplet chemo plus immunotherapy? I know some of you may use it, right?
Usually we use GM6 plus immunotherapy, but I think in certain conditions, maybe we if the tumor burden is heavy and we want to control the tumor as soon as possible, or we want to conversion to surgery, I think we can use GAP plus immunotherapy. This is my opinion. I think Professor Tao maybe for supplement.
Yeah, I think GAP plus PD-1 we use this regimen sometimes in a very typical situation, just like conversion or tumor burden is a very heavy, good PS ECOG PS 0 or and good liver function. So I think a majority of these patients we choose GC plus PD-1. Yeah. So I have a question for Professor Chen. Just now you mentioned for advanced BTC, local advanced or advanced BTC, the local regional therapy combined the systemic therapy, just like the local, just like HAIC or case. So I think it's very different from liver cancer, just like such as blood supply or bio behavior. So I think that is very different from HCC. So what's the best choice if we want to use the local therapy?
That's a good point. In my experience, not clinical trial, is if the patient with inoperable tumor to start with, either local advanced metastatic, if they demonstrate quite reasonable good response to the initial TOPAZ 1 or 966 or whatever systemic therapy regimen, if afterwards, if they demonstrate like after 4 to 6 cycles, they're doing fine, I will try my best to review the tumor status to see whether if they're more confined to the liver. We know that those usually they tend to behave badly in the liver. I will review in the MDT to see the feasibility of some aggressive local regional therapy if the patient is willing, if the patient is relatively young. My anecdotal experience is this can help delay the progression or delay the resistance in the liver. In my experience, I offer local regional therapy like Y90, sometimes TCE, or sometimes radiotherapy, depends on the tumor burden. I know this is not high level, but because we know that for those patients, they tend to do badly. Even with second line, they are not doing great. So I use the first line systemic to choose the biology. If, of course, the patient behave badly, progress outside the liver, or with very aggressive biology, I will not offer this treatment. It's only reserved for those patients with more responding disease. Going back to your second question is about the vascular supply. I agree with you. IR opinions is important. Usually, like Y90, we know that the TN ratio is lower. We need to give a higher Y90 dose to those tumor. So usually we more like local approach so that we can give a higher dose to one side instead of long selectively to the whole liver. Or sometimes we give just local like radiotherapy. So this is our experience. So it's a highly selection and in terms of tumor, vascular supply, and biology.
Thank you. So the local treatment is after the standard of care. Yeah, thank you. Thank you for our speakers and our discussion experts.